and I will get David Rothberg from University of Utah to share his screen, and we will open the session with a talk on pediatric pelvic and acetabular fractures. So David, I'll turn it over to you.
Good morning. Thank you, Steve. So we are going to talk about pediatric pelvis and acetabulum fractures, and a lot of this has been borne out in my experience living in Utah, where everyone has 5 kids and 2 trampolines. So we tend to see a lot of pediatric injuries despite being a relatively small state. So at the end of this talk, you're going to be able to answer a couple questions. One, what are the operative indications in pediatric pelvis fractures? What are the acetabular fracture patterns, and when and how do I respect the growth plate? So let's start with some of the fundamental differences between kids and adults in regards to their pelvis. Number one is that particularly in the younger kids, their bones, joints, and symphyseal cartilage are considerably more malleable and elastic. Their periosteum is much thicker, so they can absorb a lot of injury, a lot of force before you're going to see anything akin to adult-style patterns. The other major difference is that they have growth plates and apophysis. The one most concerning to us is the triradiate at the acetabulum, and injury to that can lead to deformity, which we'll cover. And the other component of this is the physiologic response. So in kids that do have high energy trauma to the pelvis, which at least here is generally kids unfortunately getting run over in their driveway by a car or trailer. What happens with kids is that physiologically, when we're managing the high energy pelvic disruption, they are not going to show the same signs of shock as an adult will until they're really far along and ready to collapse. And so we have to remember that physiologic support of these kids looks a little different, and we have to be wary of when they're going to drop off the cliff. The last part, and a kind of a theme to this talk, will be that utilizing some of the things that you have learned in the adult components of this course are still exceedingly important in the kids. Our tendency is to think that because they're kids, they'll remodel and they'll be fine. But the reality is that many of the injuries that they have are through articulations, and articulations do not remodel. And so this is an example of a kid who had a injury to the pelvis, and you can see the displacement of the right sacroiliac joint. And it was left alone with the assumption that this would remodel, and that what they were seeing on this repeat CT scan at 7 weeks was remodeling. And while you can see the periosteal tube thickening anterior on the ilium, this is not articular cartilage. And I think at best, if in a patient like this, what you're going to see is a fusion of the joint in a deformed position. And so the remodeling in the pelvis is not as significant as it is in the diaphysis of long bones, and I would implore you to remember that, and we'll go over that in greater detail as we move through the talk. So in regards to development in the pelvis, what do you really care about? Number one is identifying injuries. So the pubic symphysis width, what is it at age X? What is the SI joint width at age X? And what size are my fixation core, or should I have an unstable and displaced pelvis that needs to be fixed? So through CT study, the pubic symphysis width has shown to not differ a significant amount over time. And so the really young kids will have a 5 millimeter width to their symphysis up until about age 12 to 15, when we're having a more adult size pelvis. And you see that really that width stays relatively similar at about 4 to 5 millimeters. The SI joint, or sorry, what you're seeing here basically is a 3-year-old female that had an open book pelvis fracture with significant symphyseal widening, and where it should be once it's closed. So you're just seeing an example of what the width of the symphysis should be at that age. What about the SI joint? It differs a little bit more over time, but still it's not significant. In the really young kids, similar to the symphysis, you'll see about a 5 millimeter width of where the cartilage is, decreasing to about 3 millimeters at the age of 16. In reality, in the SI joint, because most injuries are unilateral, not all, but most, you have a template to look. And so you look for side-to-side symmetry, but here's some numbers in case you don't have that. Now, if you have a pelvis that needs to be fixed, and we're thinking about fixing them in the way that we might fix an adult, we then ask the question, is that safe? And do we have the corridors? And so in the sacrum, generally speaking, in most kids, we have very safe corridors with greater than 7 millimeters of pathway at S1 and S2 in a vast majority of patients. So we're starting to see that the symphysis, the SI joint, are not that much wider than in adults. So that makes it easier for us to evaluate instability. And that if we need to fix them, it's actually quite safe to do so utilizing the same techniques as we do in adults. The classification system that you'll see for both pelvis and acetabular fractures are not very good. And so the Trirode and Zieg talks about avulsion, iliac wing, anterior ring, straddler combined, but it doesn't really give us much of an anatomic consideration, and it certainly doesn't help us with stability. So for me, I like to think about these in the same way that I think about adult fractures, both mechanistically with a Young and Burgess and anatomically in the Letronel type descriptions, as well as stability in the AO or tile classifications. And I think that for the most part, that kind of holds true in kids, that you can utilize those. So for kids that are above 12 to 14 that have a triradiate that's closed, I just treat them like adults. And on those that are younger, I'm going to base my decisions on what to do with a pediatric pelvic fracture based on instability, displacement, and remodeling potential, knowing that in general, greater than 1 centimeter of asymmetry in a pediatric pelvis is not going to remodel. And so if you've got a hemipelvis in which you don't have the same hip heights, or if you've got one where you have a significant internal or external rotation to one half or both halves of the pelvis, you can't expect that to remodel, and they need to be fixed. In regards to instability, I think this comes in on the kids that have lateral compression type fractures, and much in the same way that we figure out whether somebody is stable or unstable in an adult, we do the same thing in a kid. I think there's some hesitation to stress a child's pelvis, but the reality is you would not hesitate to give a child propofol to reduce their both bone forearm fracture. And if your hospital's anything like mine, you do that 10 times a day. So why not do the same thing with a child's pelvis fracture that has both anterior and posterior fractures, pelvic ring fractures, that you're not sure whether they are stable. And so that's what we do in our hospital to determine stability, is we use a stress examination. And the reason that I think that that's valid in a kid is because if they stress to a position that is more than 1 centimeter or more displacement, that's where they're going to end up. And we know that doesn't remodel. So what are the non-operative fractures? Basically, almost all the avulsion fractures, anything isolated into the anterior ring, an iliac wing that's not significantly displaced and not into the joint, anything isolated, non-displaced sacrum or SI joint injury without instability that I've tested, and stable combined injuries with less than 1 centimeter of pelvic asymmetry. And I think if you're discerning, you're going to realize that what I just described is basically the same indications for an adult. So how do you do it? This is a 12-year-old female who was ejected, and then unfortunately the car rolled over her. So it took a fairly significant trauma to fracture her pelvis, but she had a significantly displaced fracture. You can see in these imaging that she has a binder on right now for hemodynamic instability. You can see the displacement of the symphysis, the triradiate on the left. Here is a CT scan with representative cuts. She's got a left sacroiliac joint fracture dislocation, right sacral fracture, a symphyseal injury where the symphysis is not quite matching up in the middle, but has been reduced by her pelvic binder. She's got an anterior column triradiate based acetabular fracture on the left and inferior pubic rami bilaterally. So this young lady was hemodynamically unstable and had a belly injury. So the same as we would do with an adult, we took her to the operating room that night in conjunction with general surgery. We evaluated for perineal open wounds. We washed out what we needed to, and we closed down her pelvic volume, much in the same way that we do with an adult. And you can see the S1, which we said was safe in most kids, S1 iliosacral screw on the left, and a fairly good reduction in the front. She stabilizes, and we measure that just in the same way we do with adults, where we're checking on blood pressure, hematocrit, lactate, looking for resuscitation parameters, and then take her to the operating room for fixation of what was a displaced left acetabular fracture, and fix the front to help us with gaining an anatomic reduction of the acetabulum. So this, you can see this is a kid who's older than 12. We said the triradiate closes at 12, and despite the fact that she fractured through the triradiate, we know there's not significant growth left, and we cross the triradiate with a recon plate. And this is her 1 year post-operative. We elected not to take out the hardware because she is nearing skeletal maturity. Now this is that same 3-year-old before. Again, this is another kid who's run over in the driveway, and has an open vaginal laceration with bleeding per the vagina and an open book pelvic fracture. And just like an adult, we're going to examine the genitourinary system. We go to the OR with OBGYN. We open her up through a fan and steel. But this time, with the size of the patient and knowing that because she has a significant amount of growth left and that we have an apophysis on either side of the symphysis, we choose to get her reduced and actually suture fix the symphysis. Now that's not strong enough over time, really, to be by itself. And so she gets an anterior-based X-fix, but the suture fixation allows us to have washed out the open pelvic fracture, get a good reduction on the symphysis, and here she is at 6 months with some residual deformity that is less than 1 centimeter, and we would expect to remodel. So we've been talking a little bit about the triradiate cartilage. So talk about what happens when it's injured. And it seems that for the most part, this actually happens significantly more in pelvic fractures than it does in acetabular fractures, despite the fact that acetabular fractures are going to fracture through the triradiate. The reason for that being that older kids are the ones that are getting acetabular fractures by and large. And so you're not seeing a lot of deformity from growth arrest in the triradiate versus pelvic fractures that can happen at younger ages or seem to mechanistically. And so you may get fracture akin to a pubic root fracture that goes through the triradiate. So I'm just showing a picture here of a 1-year-old, and you can see a significantly large triradiate versus the image of the older child with the arrow showing you where the triradiate is. And it's a fairly T-shaped cartilage pattern along the quadrilateral plate extending out to the rims both anteriorly and posteriorly. So the significance of an arrest is that if it happens at a young enough age, what you see is somewhat akin to DDH or developmental dysplasia, but it's a little different because in developmental dysplasia, you see an anaverted femur under coverage of the lateral and anterior component of the acetabulum. After a pelvic fracture, the triradiate injury, what you see is teardrop thickening, some lateralization and cranialization of the head. And it depends a little bit on where the triradiate was damaged, whether primary, anterior, or posterior. But this is a kid who wasn't really caught over time and now has lateralization and uncovering of the head because of a triradiate cartilage. And this is a patient that I took care of this year who was treated at an outside hospital, had a very reasonable reduction of the pelvic ring and appropriate treatment at 6 years old. And the outside surgeon noticed that the right triradiate started closing down from this pubic root fracture. This was a non-articular fracture, but did involve the anterior column component of the triradiate. You see a bar forming here at 9 months. And starting to see the head lateralize. So there's more uncovering here of the head. And so just like any other physeal bar in a young child, we're gonna resect that. And so that's a picture of what we did. This was through the middle window. And you can see down here where the bar now is gone. This is an intraoperative photo showing you through the middle window. We've got vessels here. This is healthy cartilage. This is the area here where we resected the bar. And she's only 6 months out now. So we'll, if you come back next year, I'll show you where she's at. So taking you from that, we'll move on to acetabular fractures. These are pretty rare under 10 years of age. We don't tend to see the mechanism causing acetabular fractures at that age. We do tend to see pelvic fractures, but not acetabular fractures. We said that the triradiate closes somewhere between 12 and 14, depending on sex and physiology. And so this is a pretty small window of kids that are going to have an acetabular fracture that is different than the adult. So this is an 11-year-old male with a posterior wall fracture dislocation versus a 13-year-old male with a posterior column-based fracture here through the triradiate. And we'll go through in a little more detail this in a second. The original classification for these is the Watts classification. I do not find this helpful whatsoever. What we have learned about the Letournel classification is that it helps us to define which components of the bone are fractured and how we can approach it. This Watts classification doesn't do that. So for me, I don't really put a lot of stock in it, but instead start to lump pediatric acetabular fractures in 3 groups: elementary wall patterns, fractures with triradiate involvement, and those with adult patterns. And so once their triradiate is closed, we're not really talking about a pediatric fracture anymore. They tend to just be adult acetabular fractures. And so kids will get posterior walls, elementary anterior walls as well. And then the fractures that they have through the triradiate are either going to be anterior, posterior, or both based fractures through the triradiate, meaning either low anterior column, low posterior column, or T-shaped fractures. And I'll show you some examples of that. This is an elementary wall in an 11-year-old who was playing football and was landed on his back with a flex knee trapped under him, and he had a dislocation. When you look at pediatric posterior walls, it's very difficult to identify the wall. It's a very small piece of bone up here. Still, some of the rim is cartilaginous at 11. And so hanging your head on any kind of size measurement on X-ray or CT is very difficult. So the same question comes up that you would ask in an adult is the hip stable? And so again, I would implore you to utilize the stress exam like you've learned in adults in kids, because that's what's important. So this kid got a reduction, and you can see that the head is still lateralized. Now in an adult, we would just assume that we probably have some bone in there and put them in traction. In a kid, I want to show you what can happen and tell you why I think when you see this, or really any posterior wall fracture dislocation, this kid deserves an MRI. The reason for the MRI is you see a lot more of that cartilaginous rim structure that you don't see in an adult. And so what happened to this kid, and that I've seen a few times now, is that upon the reduction, the fracture included part of the labrum, and when we pulled the head back in, we actually delaminated the cartilage with the labrum, and that is what's holding the head out lateral. And so what you're looking at here is a coronal image showing the delaminated cartilage and the posterior superior aspect of the hip versus the axial on the left that shows you where the posterior wall fracture is. And so this is a kid that then needs to go to surgery. And we chose to do a Gibson approach with a surgical dislocation. They're 11 years old. You can do a trochosteotomy 9 or older pretty safely without damaging the greater trochanter apophysis. And then we fixed the posterior wall with suture anchors because of the size of it, bringing the labrum back, more of a labral repair for stability. And at 18 months, there's no AVN, and healed well and is stable and back to getting ready for his next injury, playing football. Now, the triradiate involvement fracture, as I said, come in anterior and posterior or T-shaped flavors based on the shape of the triradiate cartilage. And so this is a 14-year-old male that we follow the iliopectineal and ilioischial lines, and we see disruption of the ilioischial line. Therefore, we are dealing with a posterior column triradiate-based fracture versus the 11-year-old male, where you can see that they have the anterior-based fracture as well, both coming through triradiate here. Here's the CT scan of those. On the posterior based fracture, you can see the displacement through the triradiate here that comes down through the acetabular roof. On the 11-year-old, the anterior fracture. So now we've determined, based on Letronell's classification, where this fracture is using our radiographic lines, and it's all starting to come full circle, and now we can choose an approach. So for that the posterior based fracture, they got a Coker-Langenbach approach, much as we would do in an adult. We had a posterior column plate, much like we do in an adult. The one thing that's a little different is that you can see I used a 4-5 cannulated screw as my lag screw. These fractures rotate in the same way that a posterior column would in an adult, but just rather than through the ischiopubic segment, it tends to rotate through the triradiate fracture, heading in a caudal to cranial direction. And so the position of the lag screw based on the triradiate is a more vertical position. And so when I'm doing, when I've got this fracture reduced, I use a cannulated screw because the trajectory of the lag screw comes from outside of the wound of the Coker-Langenbach. And so that's why I use that. Now in the anterior based fracture, it's going to be an anterior column plate, just like we would in other anterior column fractures. And this is him at 6 months. The question then becomes, what happens in the younger kids where the triradiate cartilage is still open? And so we said it closes at 12 to 14. The reality for most kids is that past the age of 10 or so, there's not a lot of remodeling or a lot of growth still going on in the acetabulum. And so that's in general, my cutoff is about 10 years of age, pending what they seem like physiologically compared to their parents or older siblings. But this is a kid who you look at their pelvis and it's small, it's still immature with an anterior based fracture. And so in order to respect the triradiate cartilage and not cross it with a plate, we are buttressing cranially and caudally to the fracture line and then using a K-wire across the triradiate to stabilize. And that K-wire is coming out this cranially through our lateral window, allowing it to be pulled in the office at 6 weeks. And you can see the reduction of the anterior column here. And so that's my strategy for respecting the triradiate in those under 10 is buttressing on either side of the triradiate and utilizing smooth K-wires across the triradiate that can be removed. Now, not always do you guess right. And this is I just think it's an interesting x-ray. This is a kid who got an anterior column-based triradiate fixed, was lost to follow-up and did not have plate removal. You can see where the triradiate grew and sheared the fractures. So the growth plate was still growing. And as my senior partner would say, behold the power of the human growth plate. So in summary, operative indications in pediatric pelvic fractures are still based on displacement and stability, just like they are in adults, knowing that a kid is not going to remodel greater than 1 centimeter of displacement very effectively. That our acetabular fracture patterns are still going to follow a Letronell style pattern, but be based through the triradiate. They will still dictate our approach. And that respecting the triradiate growth plate is important based on age, with a generalization of 10 years of age based on projected growth and closure. But there is a little bit of art to this based on, you can have 12-year-old boys that are 5 feet tall and dad's 6'4", and that happens on occasion. And even though that kid is 12, I would still likely respect the triradiate because of how much growth is going on. So there's a little bit of art to that. But the major summary here is I still think about these very much like we do adult fractures, and would ask you to use much of the same indications that you would in adults. Thank you.